Welcome to another lecture on my YouTube channel, Rounds in the Fast Lane, which I created to help interns, residents, and medical students with the most common topics in practical medicine. Today's lecture is on IV fluids, something that you will commonly come across in the hospital setting. And also, it is one of those topics which is most commonly confused amongst the students and the residents, especially when they initially join their residency programs. So, this lecture I'll be dividing into two parts. The first part, I'll be discussing the basics of the body fluid compartment, different types of fluids that are available, the basic calculations which are involved in deciding how much fluid you're going to give, and does your patient really require fluids. In the second part of the lecture, I'll be discussing the evidence behind choosing one fluid over the other, and also using fluids in different common medical conditions that you will come across in the hospital setting. So let's start with the body fluid compartment. Now, consider all the water that's there in your body in the form of a tank. Now, let's say an average male weighing about 70 kgs, about 60% of his body is water, which means if the weight of the patient is about 70 kgs, about 60% is 42, which means 42 liters in their body is water. Now, this 42 liter is considered as being a part of the tank. About 2/3 of the body water is in the intracellular compartment, and about 1/3 is in the extracellular compartment. Then, in the extracellular compartment, about 80% is in the interstitial compartment and about 20% in the intravascular compartment. Now, water can freely move between these three compartments, which means that if you pour a bucket of water, let's say if you pour 1 liter of water over here, it is going to freely go and diffuse into these three compartments until 2/3 of it is reached over here and 1/3 remains here, with 80% in the interstitial and 20% in the intravascular compartment. On the other hand, electrolytes cannot cross freely between the intracellular and the extracellular compartment due to the plasma membrane. The transport of electrolyte happens over here only with the help of special channels or active passage with the help of, for example, sodium potassium ATPase. Otherwise, electrolytes cannot freely move around between these two compartments. However, they can freely move around in these two compartments. So let's say if you pour a bucket of water that is containing electrolytes, the water will freely move amongst these three compartments, but the electrolytes can only move between the interstitial and the intravascular compartment. Now, what's the difference between these two? Proteins and large molecules and also cells, they cannot move between intravascular and interstitial compartment. So for example, if you pour a bucket full of blood in the intravascular compartment, it's only going to remain over here and it is not going to be able to freely move between these two compartments. And of course, it's not going to come into the intracellular compartment. So this is something that you're going to have to remember now. And as I move forward, I'm going to explain why is this logic important. You need to remember 2/3 remains in the intracellular, 1/3 in the extracellular, and 80% of that 1/3 remains in the interstitial and 20% of that in the intravascular compartment. Proteins and cells cannot move between the intravascular and the interstitial. Electrolytes can, whereas electrolytes cannot move between the extracellular and intracellular compartment, and water can move wherever it wants. Now let's discuss the most common types of IV fluids. The two big groups are crystalloids and colloids. Crystalloids is nothing but those fluids containing water and electrolytes or water-soluble molecules, and colloids are large insoluble molecules, which includes proteins and blood products. What's the difference? When I speak about crystalloids, some of the most common crystalloids that you're going to come across that you always hear when you join your residency or when you're joining your internal medicine rotation in your hospital, they are normal saline and lactated ringers. And the colloids are, you must be hearing about different blood products, that is packed RBCs, fresh frozen plasma, platelets, and then albumin solutions. These are all colloids. Now, crystalloids are of three types: hypotonic, isotonic, and hypertonic, based on the tonicity in relation to that of the plasma. Now, the normal osmolality of the plasma is between 275 and 295. So that means anything that is hypotonic, if you're going to put through the IV line, it's going to start moving from the intravascular to the interstitial, and from the interstitial to the intracellular compartment. So hypotonic fluids have the tendency to move towards the left into the intracellular compartment. Isotonic fluids, which have similar osmolarity to that of the plasma, have the tendency to stay in the extracellular compartment, and there will be no net shift in between the extracellular fluid and the intracellular fluid. Hypertonic fluid, which has more osmolality as compared to that of the plasma, has a tendency to pull the fluid into the extracellular compartment. So if you put through the IV line, if you put hypertonic fluid through the IV line, it's going to start pulling out fluid from the interstitial and eventually through the from the intracellular compartment. Now, what are the most common fluids that you come across in the clinical practice? Of course, normal saline, that is 0.9% normal saline, and lactated ringers are the most common names that you must have heard about when you join your rotations. 3% normal source saline is the hypertonic saline, and half normal saline is the hypotonic saline. Plasmalite is another type of isotonic fluid that we use. Now, I'm not going to dive deep into the concentration of different electrolytes in these fluids. I'm just going to focus on the most important points that you need to remember. You also don't need to remember the osmolarity of these fluids. Just try to understand how these fluids are different from each other. Now, normal saline and LR, what's the difference? Both of them are isotonic fluids. Normal saline has a little bit higher osmolality as compared to that of the plasma, and lactated ringers and plasmalite have almost similar osmolarity to that of the plasma. The difference between lactated ringers and normal saline is that normal saline has a very higher concentration of sodium and chloride as compared to that of the plasma, whereas that of lactated ringers and plasmalite is almost similar to that of the plasma. Lactated ringers and plasmalite also contain a little bit of potassium in them, and there are also other electrolytes which I will not be going into, because you don't need to remember these electrolytes. You just need to understand how these three different isotonic fluids are different from each other. So the main difference between normal saline, lactated ringers, and plasmalite is that these two, lactated ringers and plasmalite, are balanced crystalloids, and normal saline is not, which means that the concentration of sodium and chloride is a bit higher as compared to the normal plasma, and the concentration of sodium chloride is almost similar to that of the plasma in case of balanced crystalloids. Hypertonic saline has a very high osmolality. As you can see, it is 1030 as compared to the normal osmolarity of the plasma. And hypotonic saline is half normal, that is 0.45% saline, and has the osmolarity of 154 and has 77 of sodium and 77 of chloride. You don't need to remember these numbers. Just remember that which one of them is isotonic, which one of them is balanced, and which one of them is hypertonic and hypotonic. How they are different is what I'm going to explain in the next slide. Then there are some other common fluids that you will come across, which are initially hypertonic, but as they are metabolized, they become either isotonic or hypotonic. The most common one is dextrose-containing fluids. Now remember, dextrose-containing fluids have either 5% dextrose, that is 50 gram per liter, or 100 gram per liter, that is D10, what we call D10, and it will have about 170 calorie in D5 and 340 calorie per liter in D10. Now remember that they do supply glucose, but they are not a source of nutrition. So they might help you prevent hypoglycemia in a patient, but they are not used to provide calories, because you can see the amount of calories in each of these fluids. When are we going to choose them? How are we going to use them is what I'm going to discuss later. But this is just a type of fluid that you need to understand. Now, let's say we are using dextrose 5% in a liter of water. It has an osmolality of 253. And as the dextrose is metabolized, it is converted into free water, which is hypotonic. The reason this is important to understand is that you cannot use hypotonic fluid faster through an IV line, because it's going to cause the lysis of the red blood cells, and you do not. So that's why when we try to infuse fluids, they are mostly isotonic. And later on, when there is shifting of the electrolytes, or there's metabolism of those products, the fluid changes its tonicity. Similarly, dextrose 5% with half normal saline is hypertonic, but as the dextrose is metabolized, it is converted into half normal, and that is hypotonic. Dextrose 5% with normal saline is again hypertonic, but as it is metabolized, what remains is normal saline, which is isotonic. Dextrose 5% with lactated ringers is hypertonic, but as the dextrose is metabolized, it becomes isotonic, and what remains behind is the lactated ringers. 10% dextrose in water is also hypertonic, but when the sugar is metabolized, the glucose is metabolized, it becomes free water, which is hypotonic. Now, why are these fluids different from one another, and what's going to happen when you infuse these fluids through the IV lines? Now, let's say start with the D5 water. When you try all these fluids, try to imagine that you're using a bucket of water and you're infusing them through the IVs into the intravascular compartment. Now, if you infuse D5 water, it's like giving free water to someone. And as I said before, water can easily diffuse between the compartments, and they're going to distribute as, now let's say you're using 1 liter of D5 water and you pour that bucket of water into the intravascular compartment. It's going to start redistributing, go into the interstitial space, and eventually into the intracellular compartment. So about 2/3 goes into the intracellular compartment, which is about 667 ml, and about 267 ml remains in the interstitial compartment, and only 66 ml of this free water remains in the intravascular compartment. Now, normal saline and lactated ringer, which is crystalloid, either balanced crystalloid or normal saline, let's say 1 liter, you pour into the IV lines into the intravascular compartment. As I told you before, electrolytes can redistribute between these compartments, and hence the isotonic fluid will only redistribute itself between the extracellular fluid compartment, and about 800 ml, which is 80%, is going to go into the extracellular fluid compartment, and 200 ml is going to go into the intravascular compartment. Now, let's say you're using D5 half normal. Now, a liter bag of D5 half normal, you can think of it as a 500 ml bag of D5, which is free water, and normal saline, 500 ml of normal saline and 500 ml of D5 water. So D5 half normal can be thought about like this, and you can imagine what's going to happen. 500 ml of D5 water is going to go freely between all the compartments. So 333 ml remain over here, and 134 ml remains in the interstitial compartment, and only 33 ml is going to remain in the intravascular compartment. Whereas the normal saline is going to distribute itself only between the interstitial and the intravascular compartment, which means 400 ml goes over here and 100 ml over here. Hypertonic saline, on the other hand, is going to pull the fluid towards the intravascular compartment. That includes from the intracellular fluid to the interstitial, and from the interstitial to the intravascular. So this is how the fluids travel. The reason this is important is because later on, when I'm going to teach calculations, you need to know, whenever you give a liter of fluid, where is this fluid going to go and how much of it is going to remain in which compartment. So if you're going to try to support somebody's blood pressure and you're going to give a liter of normal saline, only 200 ml remains in the intravascular compartment after redistribution. Now, this is the initial redistribution, and later on what happens to the fluids and the electrolytes is based on the homeostasis of the body. The body might try to, based on the activation of the pump, might try to redistribute everything, but this is the initial redistribution of all the fluids, what happens when you infuse them through the IV lines. So it's very important for every fluid, you need to understand what happens to the hypotonic fluid, how it travels, isotonic fluid, how it travels between the compartments, and the dextrose fluids, how they travel and what's going to happen, what's the end result. On the other hand, if you look at colloids, as I said before, since large proteins and cells, they do not cross the compartments between interstitial and intravascular, everything that you pour is going to remain in the intravascular compartment. So if you're giving somebody a 300 ml of blood, a unit of blood, it's going to only remain over here in the intravascular compartment. So you can think how much of it is remaining over here. If you give a liter of NS, only 200 ml of it is going to stay in the intravascular. And if you give a liter of blood, the whole liter is going to stay over here. So once you understand this, it will be easier for you to judge which fluid to pick, where is it going to go, in which compartment. Now let's talk about some of the basic calculations which we do to arrive to the conclusion of how much fluid you're going to give to your patient. Based on different conditions, these calculations might change a little bit, which I'll be discussing in the second part of this lecture. But just for the basics, starting with the calculation. Now, let's say you admit a patient, about 70 kg patient, who comes in and is very dehydrated. Now, there are two types of calculations that you must be aware about. That is the resuscitation fluid that you will give initially to rehydrate the patient, bring them to euvolemia, and then the maintenance fluids. Resuscitation fluids that you will be giving will be for the existing water and electrolyte deficit that the patient has, and maintenance fluids are the one that you will be giving for ongoing water and electrolyte loss. Now, let's say you admit this patient and his weight is 70 kg. Resuscitation fluids are about 20 to 30 ml per kg, which means this patient will require at least 2.1 liters of fluid to resuscitate. You give 2.1 liter, usually it is given as a bolus, and then you will see that the patient is still dehydrated based on the signs, which I'll be discussing further. And that's when you will repeat this and give about 1 to 2 liters more as a bolus, and again assess the patient if they need more. Once you have resuscitated the patient, then you will calculate the maintenance fluids. I usually use this formula, which is a bit easier. That is 1500 ml for the first 20 kgs, followed by 20 ml per kg for the rest of the weight of the patient. So let's say if the patient's weight is 70 kgs, you will give 1500 ml for the first 20 kgs, subtract 20 from this 70, that is 50, and you will give 20 ml per kg for that over a period of 24 hours. So over the period of 24 hours, the patient's requirement is about 2500 ml. And if you divide it, it's going to be approximately about 100 ml. That is 104 ml per hour, which is approximately about 100 ml per hour. Now, you could also use the 4 to 2 to 1 rule, which is 4 ml per kg for the first 10 kgs, 2 ml per kg for up to 20 kgs, and then 20 kg onwards, you will use 1 ml per kg. And your approximate rate is going to be similar, that is 110 ml per hour as compared to this one. Now, most of the adult patients are going to be more than 20 kg. That's why I used 1500 ml for the first 20 kgs. It's about a similar calculation. This calculation will give you the 24-hour requirement, and this will give you the hourly rate. You can pick and choose whichever you want for the maintenance fluid. The point I'm trying to make is whenever you admit a patient, or if you're a new intern or med student, you go to the hospital, you see that the patient is on 75 ml per hour or 100 ml per hour of fluids. These all fluids are not randomly started. There is a calculation behind it, and you need to understand how these calculations are different from one another. Resuscitation fluid calculation is different as compared to maintenance fluid. Will all your patients require maintenance fluids? No. If a dehydrated patient is coming in, is able to eat and drink, doesn't have any renal dysfunction, and you rehydrate them, you resuscitate them with this formula. Let's say you give them 2.1 liter of fluid bolus. Bolus is usually about 1 liter over a period of 1 hour. You give 2.1 or 2 liters, which is about, you'll give 2 liters over a period of 2 hours. You assess the patient, they have been rehydrated, they are able to eat and drink, they are no longer dry, so no, they are not necessarily going to need maintenance fluids if they are able to tolerate oral intake. Not every patient is going to require maintenance fluids. Which fluid you're going to pick is what I'm going to discuss later, but these are the calculations first which you need to understand. Now, let's say the same patient who is coming dehydrated also had other problems, or let's say they are altered, they are not able to eat and drink like a normal person would. You would initially can start them on maintenance fluid for the ongoing water and electrolyte losses. So you can give 2.1 liter. If they're not getting better, they're still dry, you will again give them a liter or 2 liter bolus with resuscitation fluid, and then start them on maintenance fluid. The same patient, if you admit them and just start them on 100 ml per hour, it's not going to work for them. So this is something that's very important that you need to understand. Now, before we discuss how to assess whether or not the patient needs fluids, we're going to discuss the Frank-Starling law. You must have heard about this in your basic sciences exam in the med school. Frank-Starling law is the curve which is a relationship between the stroke volume and the preload, which means that if the preload increases, the stroke volume increases due to increase in the stretch of the myocardium tissue. So due to the increase in the stretch, there is more and more of contraction until a certain point, after which there is no relationship between the stroke volume and the preload. So if somebody stands over here on the curve, if you give them more volume, that is, you give them more preload, their stroke volume increases. Now, for whatever reason, let's say a patient is hypovolemic due to bleeding, hypovolemic due to dehydration, hypovolemic due to sepsis. In all these cases, we would assume that when the preload will increase until this part of the curve, the stroke volume will increase. Now, some patients can be hyperdynamic, some patients can be hypodynamic, and some patients like this over here can be in cardiogenic shock. So based on where they stand on this curve, their response to the fluid is going to change. Now, there are two different types of indices. That is the static measurements and the dynamic measurements. Static measurements tell you where the patient stands at one particular point in time on their fluid responsiveness. The dynamic measures are better, but they have a certain criteria. Now, what are static measures? Now, does your patient need fluids will depend upon two things. Over here, I'm going to discuss the static measures. You can look at the patient's vitals, that is, if the patient is tachycardic, along with patient being hypotensive, the patient can have a high respiratory rate to blow off more CO2, the patient can have a low urine output. All these things in the vital signs give you an idea that the patient is possibly hypovolemic. On the physical exam, never forget to look at the patient's mucous membranes. Whenever you examine a patient, ask them to stick out their tongue, and usually dry mucous membranes give you a better idea, give you a good idea if the patient is hypovolemic or not. Other signs of hypoperfusion which might or might not be present, for example, cold and clammy extremities, altered mental status, then decreased capillary refills, weak pulses, all these signs on the physical examination tell you if the patient requires fluids or not. Then looking at the labs, BUN and creatinine, rise in the BUN and creatinine, which look more like pre-renal, that is, the rise in the BUN is way more than the creatinine and the ratio is more than 20:1, give you an idea that the patient is possibly intravascularly depleted. Now remember that all these signs and symptoms that we are talking about, you have to take them into account in the current clinical context. Like, for example, the patient can be in heart failure, be hypervolemic, be in cardiorenal syndrome, and still have a high BUN and creatinine with a ratio of more than 20:1. It can look like pre-renal, but actually the patient is hypervolemic. You cannot be giving them fluids. The patient can have a high hematocrit. They can be hemoconcentrated. Whenever you look at the labs in the morning and you see the shift in the labs when you look at the cell count, the white count, the hematocrit, the hemoglobin, the platelets all move in the higher side, in the higher direction. It gives you an idea that the patient is more hemoconcentrated. Then rise in the lactic acid. Now remember, lactic acid increase usually is a sign of hypoperfusion. That hypoperfusion can happen due to any reason. Like, for example, the patient can be in cardiogenic shock, be not fluid responsive, and still the lactic acid will be high. That's why what I'm trying to say is that all these things that you use, you always have to use in the clinical context. The patient can have hyponatremia due to the loss of water and electrolytes, and can also have hypernatremia when they have a free water deficit. The patient can have a rise or fall in the potassium. Then coming to the central venous pressure, or CVP, which you usually measure with the central line, this is again a static measure. And why is that? Now, if you consider CVP, it is usually a measure of the patient's preload. That means the higher the preload, the higher the CVP will be, and the less response to the fluids is what you will get in the patient. But this is not true. It is just a static measure that is that one particular point in time. What I'm trying to say is, now let's say there is an elderly individual, an 85-year-old man who has a non-compliant stiff ventricle. He might have a little bit higher CVP at baseline, and they still might be very well responsive to fluids. On the other hand, a same 25-year-old male, if they come in with a CVP of 16, they will not be fluid responsive if they have a normal ventricle. A patient can have right-sided heart failure, and in them, the CVP will be high at baseline, and they still might be fluid responsive. A patient can have long-standing COPD, emphysema, they might have elevated right-sided pressure, and then CVP will be a false measure for them, for you to decide if you want to give more fluids or not. So that's why what I'm trying to say is all these static measures you have to take into account in the clinical context. Similarly, looking at the inferior vena cava, nowadays we have a POCUS which is readily available in almost all the hospitals that you train at, especially in the United States. You have a bedside POCUS that's available almost everywhere, even on the floors. You will have them in the ICU, but you can also have them on the floor. You can have the butterfly device, which is easily connected to the phone, and you can take a look at the patient's inferior vena cava. Now, again, just looking at the diameter and collapsibility of the inferior vena cava is again something similar to looking at the patient's central venous pressure. And if you look that the patient has a distended vena cava and it's not collapsible, it's usually a sign that the patient has high preload and they may not be responsive to fluids. Whereas if somebody has an IVC that is easily collapsible with respiration in a spontaneously breathing patient, then you can consider giving them more fluids, and it's a sign of hypovolemia. But again, you have to take everything into account and decide whether or not this patient needs fluid. You can look at the IVC in the subsequent view, and this is how it's going to look like. And you're going to see over here if it's collapsible or not, and if it's distended. So again, both the limitations of the CVP and the IVC will remain the same in patients who have a non-compliant stiff ventricle. IVC can be dilated, but they might end up being responsive to fluids. So there is a better index, that better measurement techniques that you have. That is the dynamic measures, which look at the relationship between the heart and the lungs. These are really good measures, and they are much more accurate than static measures. The problem with them is that there are certain criteria that needs to be met before you decide that you're going to use these dynamic measurement techniques. First of all, what are the types? Number one, the pulse pressure variation, which you can see with the help of the A line. With the inspiration and expiration, the patient will have a variation in their pulse pressure, and that you can calculate. The machine can calculate it for you, and if it is more than 30%, 13%, the patient will be fluid responsive. Then similarly, stroke volume variation. To measure the stroke volume variation, you need to have special equipments, like for example, a flow track that is connected. And same with inspiration and expiration, the change, if the change is more than 13%, the patient will be fluid responsive. Another thing is inferior vena cava distensibility index, which you can calculate, and you can do an M mode. Similarly over here, as I've shown you over here, there's an M mode that you can, if you press the button of the M mode and calculate it, if it is more than 20%, if it's more than 12%, you can give more fluids to the patient. Then another one is subaortic peak velocity. You can use a pulse wave Doppler that's there on the POCUS device or the echo machine in the apical 5-chamber view. And if it is more than 12% variation, you can give more fluids. Now, how do you do a subaortic peak velocity? How do you look at the IVC distensibility index? You can look up multiple videos online which teach how to do that. I'm not going to go into the details, but these are the main dynamic index. Now, what are the problems with these dynamic? What are the limitations? The major limitation is that you cannot use it in a spontaneously breathing patient. As I said over here, you can use a CVP and IVC. Just look at the IVC diameter and the these measurement techniques. You cannot use them in a spontaneously breathing patient. The patient needs to be mechanically ventilated. The tidal volume needs to be at least 8 ml per kg. The patient should have moderate PEEP, that is 5 to 10. They should have normal intra-abdominal pressure, and they should have a normal thoracic compliance. They should not have right ventricular dysfunction. They should have a regular rhythm, and they should be breathing in sync with the vent. When you meet all these criteria, that's when you can actually use this. And these are the ones which you will be mainly using in your critical care setting or in the cardiac ICU, where you will be able to use these indexes, where you will be able to use these measurement techniques easily. The patients who are not having a normal sinus rhythm, let's say somebody is in AFib, you could use another measurement technique called end expiratory occlusion test, for which again you need an arterial line, and you could do an end expiratory pause maneuver for 15 seconds and look at the variation in the pulse. If it is more than 5%, you can give fluids to the patient. The patient does not need to be in sinus rhythm to do this maneuver, and the patient does not need to be in sync with the vent. So these are the dynamic measures, and you can see how they are different from the static measures. The static measures you can use on the floor, and you can use when the patient is not on the vent, whereas the dynamic measures, you need the patient to be on the vent with particular criteria that needs to be met. For example, if the patient has a really bad COPD, emphysema, right-sided dysfunction, they have elevated right heart pressures, you cannot use these measurement techniques. If the patient is on a lower tidal volume, what you could do is you could increase the tidal volume, measure this, and put them back to their baseline. Then again, the PEEP needs to be between 5 to 10. A very high PEEP can alter the results of these techniques. Now, some of the very important points that you need to remember while deciding, as I said before, that when you calculate the resuscitation fluid and the maintenance fluids, you have to see, does the patient really need the maintenance fluids? So what are you going to look for before deciding if you want to give maintenance fluids, if you want to give resuscitation fluids, if you want to give more, you're going to hold the fluids, what are you going to do? You have to keep some things in mind, especially the patient's oral intake. If patient is eating and drinking well, they might not require maintenance fluids. Then, especially in the ICU setting, you have to remember that you have to calculate net input and output every day, because if you're giving the patient pressors, if you're giving antibiotics, the patient might be receiving fluids through multiple different pathways, and they might not require more fluids, and you might push them into volume overload. So all these things you have to take into account: if the patient is making urine or not, if the patient is in AKI, if the patient is receiving dialysis, what days are of dialysis, and when is going to be the next session, and how much of the fluid was removed in the last session. So all these things, they give you an idea what is the patient's net balance, especially in the critical care setting. Then another thing is insensible losses. The patients who are burns patient, they might have more insensible losses. Insensible losses are mainly from the skin, respiratory system, and the stools, which are not usually easily, you will not be able to calculate them, and you will not see them in your computer. So that is something that you have to keep in mind, that if the patient is burns, especially with more percentage of their body, if the patient is on the vent, if the patient is having diarrhea, all these conditions will lead to more loss of water. So they might require more fluids as compared to what you have calculated. Then one of the other things that you have to remember, especially when you're using normal saline, is that each liter of normal saline has almost 9 grams of water, 9 grams of salt. So you have to remember, if you're treating somebody actively with high blood pressure. Now remember, patient can be dehydrated and have a high blood pressure. Patient can be dehydrated and have a history of heart failure. So in all these patients, you would avoid giving them more and more salt intake. That's why you would see that usually D5 half normal is used as a maintenance fluid and not normal saline, because normal saline has a higher amount of salt. So this is something that you have to keep in mind, especially if you're using normal saline. And then dextrose containing fluids. Now remember that when you're starting dextrose containing fluids, you have to be aware about the patient's diabetic status. If the patient is having hyperglycemia, patient has a high HbA1c, patient is having uncontrolled glucose, so in those patients you would not want to use dextrose containing fluids. Again, it is not a source of supplement for nutrition. If your patient is, if you're seeing patients in the critical care setting, if you're seeing patients on the floor, the best way to provide them glucose is through advancing their diet. Giving them dextrose fluids is not a source of nutrition. So that is something that you have to remember. Then again, in the cases of alcoholic ketoacidosis and starvation ketoacidosis, giving them dextrose containing fluids will help you stimulate insulin production, increase the insulin, decrease the glucagon, and thereby decrease the ketogenesis. Again, you have to remember, not every patient might need them. The patient can be very hyperglycemic, and that's why in those cases you cannot use these fluids. So you just have to find the balance, which fluid you're going to choose. Again, remember that dextrose containing fluids increase the insulin secretion, and if the patient is hypokalemic, you can expect the potassium to drop further. So you have to keep repleting potassium in them, and you have to remember that this can further trigger the drop in the potassium. Then again, if the patient is overweight, obese patient, especially weight more than 90 to 100 kilograms. While calculating fluids for them, you would prefer using the ideal body weight and not their actual body weight, because remember, as I said before, if the fat content in the body increases, the water content tends to go down. So if a very obese patient, as compared to a normal healthy person who has about 60% of their body as water, and an obese or overweight, morbidly obese patients, they can have 50%, a lower percentage of their body as water. So that's why if the weight is very high, you should remember that you should use ideal body weight for all the calculations. So these are some of the important points. And then after this, in the next part of this lecture, I'll be discussing the evidence behind using different types of fluids. Which fluid are you going to choose? And I'll discuss a few different conditions and how things change in them. Thank you.